This is the portion where I get to ask my colleagues about some additional questions to give them a chance to elaborate some ideas, and then we will turn to you, the audience. I think that what we heard that this is even more challenging from the genetic standpoint, is that fair to say, than what we heard about schizophrenia and autism. We heard also that we have some sense of the neural circuitry that is involved, and I think one advantage in this field is that we do have animal models. So, for example, I think CAF uses like a fear conditioning paradigm, which is seen as a useful model of PTSD that also John studies in a variety of levels. So we have that advantage, and we have the advantage of thinking, of having a sense that there is more that can be done in a positive way, and that there are these moments of choice in a way that be emphasized, where you could go either head in a positive or in a negative way, and even some very rapid and dramatic treatment. So it's simultaneously very challenging, but also has many potential opportunity. And our theme is, what can we do now? So it would be interesting to just start by asking you, other than using ketamine, what do you think we can do now to help with the breadth of affective disorders? I can broaden it to my colleagues, but I'm starting.
Yeah. So, well, I think that there are a variety of ways of thinking about how to answer that question. Because one of the big challenges that we face in society is a problem related to the access to care in some ways, as much as the effectiveness of our treatments. So that 1/3 of patients who have depression will ever get diagnosed with depression. 1/3 of patients diagnosed and referred for depression treatment will follow up for that treatment. And only 1 in 10 patients with depression will see a psychiatrist. So we have a big problem with access in mental illness that is underwrites or is beneath the challenge of improving the effectiveness of care. A second level of strategy moving forward, I think, is building on some of the ideas, the computational approaches that CAF talks about, so that we have rich data sets on the symptoms and features and correlates of depression. And you can apply these same machine learning approaches to improving the match of treatment. And some of these machine learning approaches look like might have the possibility of improving the odds of responding to your initial treatment by an informed prescription by 50% or more. And that would have a huge public health impact if we could get people to more effective treatments earlier in the course of their illness or treatment. And then I think there's another level, and I would just say broadly that this approach is sometimes called precision medicine, as we try to use individual characteristics. Now, so far, the applicable models seem to be mostly based on symptoms and behavior, but we'd like them to be informed by genomics, we'd like them to be informed by epigenetics, we'd like them to be informed by a variety of informative biomarkers from brain imaging and other kinds of things. And I think the suspicion is, if we could really accrue this data in large enough data sets, that we would be able to better match to the treatments that we already have, making best use of our resources. And I would add, I'm not just talking about medication treatments, I'm talking about optimal use of exercise, diet, microbiome interventions, psychotherapies, medication treatment, whatever gets people better. And then I think are going to be new generations of more effective treatments that are more targeted specifically to the pathophysiology. It would be great to have a circuit that was not functioning right and be able to drive the circuit in the right ways, just like you can do in the animal models. And we have some deep brain stimulation approaches, but they're extraordinarily primitive with regards to what we know about different ways of modulating brain function. We just scratched the surface, I would say, there. So it's a big area, lots of new ways to optimize treatment, and very promising.
Okay, so I wanted to both give the circuit and the genetic side a chance to add or elaborate in some way.
Classically, we've had a bit of a physics problem, right? So we've had to make choices between seeing lots of the brain or seeing the brain really quickly, right? So we choose between really high temporal resolution, seeing fast signals, or seeing all of the brain in something like where we're doing human neuroimaging and we're getting a picture every second. Well, I think over time, we've evolved the ability to do both quicker, right? And so we have tools now that allow us to do both quicker. And we're finding that because, like the heart, it can integrate information across time scales, we're starting to figure out how those things fit together. I think John gave a great example of some of the more recent work being done in depression. And so we have a colleague who is able to collect large amounts of data. And one of the keys with machine learning is you just need large amounts of data. These aren't like 10, 20-person trials, right? These are hundreds and hundreds and hundreds of person trials. And he was able to basically frame the brain based on connectivity, so things changing together over time, and then map them onto symptoms of depression and different forms of treatment. And what it suggested, what the data suggested is because the brain patterns could be paired with different types of symptoms and different types of treatments, it suggested perhaps we're looking at many different diseases, right? In the same way you can have many different diseases underlying a fever, perhaps depression is like 7 or 8 diseases, each one that will respond really well to one type of treatment.
Right.
So I think big challenge is the development of causal models and novel computational methods are clearly one avenue to go. But another limitation I see is the lack of brain banks, a large number of collection of well-phenotyped brain banks with all their complexities. Right? These are dead people. They have all, the brains are not the freshest. There's the brain factor, which just sort of indicates larger numbers are required. And then having data from animal work that sort of flows back into the generation of these causal models. And without having a deeper understanding of the pathophysiology, it will be very difficult to make the link to phenotypes and treatments, ultimately.
Right. I'm going to come to you in 1 second. So maybe I will ask you now. There was an article this last Sunday about in the New York Times about how anxiety is increasing dramatically in adolescents and how devastating that seems to be and how it's coming on everybody's radar screen, more so even than depression. So my question to you is, why do you think that is? Why are these disorders rising in general and especially in adolescence? Do you have a theory based on what you've seen in your view of adolescence?
Yeah, I mean, the whole definition of what adolescence is has been changing. So, for example, in the more advanced Western societies, adolescence is going all the way to 25. So now when you're thinking about the typical adolescence of 15, we're talking about a little bit of a different animal at this point. And a lot of people might say, oh, this is terrible, these kids. By the way, a PhD is kind of like a prolonged adolescence in itself. Right. So the way that I look at it is adolescence is a time of protection to specialize. The longer, the better. Of course, there are risks that are involved in that as well. And of course, now one could argue there's a lot of competition in schools and so forth that can bring anxiety, social pressures, and social media, and blah, 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 blah. But, we are a race that is known for adaptation. So anxiety, although we perceive it as a bad thing, there is a threshold that is dimensional. And anxiety in many ways can be seen as something that's driving us towards better specialization, is one way that could be seen.
So do you think that exposure to some level of anxiety is important in developing resilience?
I think that one could very well argue that. I mean, with all of these mechanisms that we've been talking about, including stress, we need a better definition, right? What is stress? When does it, pass a threshold when it's a bad and detrimental thing? Right, and the same with anxiety. It can be when is it a drive and when is it all of a sudden coming back and impoverishing our ability to live with a normal limit.
And do you think that resilience is something that everybody could acquire, or do you think there are different limits in different people? That's my question to all of you.
Yeah, I mean, with everything, of course, it's going to be a lot of variability. Again, we can define what resilience is. I like your concept of active resilience. You know, one can think of resilience of like, oh, look at me, I'm just such a strong person, I'm resilient. But there's neurobiological, we can incentivate resilience. That means changing trajectory. So everyone has a level of predisposition for any of these disorders, right? And resilience can be many things from, you know, your environment, not just genetics. So yes, I think there's a dimensional approach to resilience as well. And I think that when we think of how to help therapeutically, the enhancement of resilience is one of the places that we should be targeting.
You know, the notion of resilience runs through everything that we do. And I, as you talk, I'm reminded of both Kafui's work and Eric Nestler's work and his colleagues, where we're used to thinking about medications that alleviate distress or alleviate symptoms. But one of the nice things from Eric's studies, for example, is that when you treat the stressed, vulnerable animals with antidepressant, they acquire the epigenetic profile of resilient animals. And there's some clinical data that suggests that a similar process happens in people, that when we effectively treat their symptoms of depression, partly what we're doing is giving them the resources to cope with the challenges of their life. And so restoring a capacity for resilience may very well be a part of the way we think about alleviating the symptoms of depression.
Yeah, so that's the idea of an active process, is that we might have the resources that we can call on, but you have to activate them. You have to couple them, right? And then you can see it biologically, and that's why I'm very grateful that you ended with the slide that shows that epigenetic modification is one of the pathways that is implicated in these disorders.
Right, but I just want to add, you know, for these common variant risk-conferring genetic variation, the risk and the resilience, risk increases, the odds ratios are very low. So it's not a lot of risk that's conferred, and it's not a lot of resilience. It's clearly opening up environmental and other pathways.
Right. Okay, I think it is time for us to open the discussion to the audience. And so if you will come to the microphones and identify yourself. Yes.
Susan Scrimshaw, International Nutrition Foundation at Tufts. And first of all, I want to thank the panel. There's so much happening in this field, and I appreciate very much what you've shared. Dr. Krystal talked about the whole issue of access. And there are two major obstacles, and I'd like some of your thoughts on them. The first one is stigma. Patients or people who are afraid to be patients are afraid of stigma, of being labeled. They're afraid that a label is going to follow them all their lives, that they won't be able to get jobs, they'll get thrown out of jobs. They're even afraid of stigma from healthcare providers. Oh, I'm going to get labeled an addict because I've been on this antidepressant for 10 years. And that leads me to the second obstacle, which is in the interests of health professions education, and I co-chair the NAM forum on that. How do we communicate all of this science that is moving so rapidly to providers out there in the world, because there is a knowledge gap and there is, if you will, a practice gap, and so that also affects access.
I guess that everyone's looking at me, so I'll respond.
Yes, it's right there.
First off, stigma is a terrible problem, and one of the things that we've done unintentionally is to separate off the treatment of mental health and addiction problems from all the rest of medical treatment. And we have to figure out how to treat people where they live, to begin the process of detection and early intervention for mental health and addiction problems in the context of their general mental health, their general medical care, and then move people out only when they can't be managed in these standard medical primary care settings. Normalizing mental health and addictions as normal problems that people have in their life will be a part, I believe, of the destigmatization process. I think at the other extreme is we need more effective treatments. If we can't treat people effectively, then the illness or problem becomes frightening to people and frightening to the caregivers who feel overwhelmed by the burden of intervening. So I think we need both the kind of public health arm of of research about how we integrate treatment, how we make that cost effective through technologies and other approaches. But I think we also need a basic understanding of what's going on in the brain, the genes, the circuits, in order to have ultimately more effective treatments. Both are needed, I think.
Thank you. And then we need to get that knowledge out to the healthcare professions.
Absolutely.
Yeah, and I would agree with that. So I'm a super hopeful, optimistic person, and I think scientific progress is what eliminates stigma ultimately, right? We had challenges around stigma, whether it was HIV/AIDS or there was a time when it was epilepsy, and the hope is by understanding the nature of these disorders and coming up with explanations and treatments and cures, we will eliminate that stigma.
Yeah, that's a really good point.
I'm Bill Hazard. I'm a geriatrician. I'm in Wake Forest, and I'm a gerontologist. I mentioned that this morning. But I think one of the wonderful things about being a geriatrician is it's all about stories. We are fascinated with the stories of people because they're long stories, and anybody going into geriatrics loves to spend time talking with people because of the stories. I think we have an opportunity maybe, again, I'm trying to be sort of disruptive and make us think about it. How do we study success? How do we study resilience? Everybody in this room has a story to tell. We're all winners. What are the characteristics and NAM members that give us the power? We all have stories to tell. What did we have to overcome? What were the things that advantaged us? What were the things we had to do throughout our lives? Because we're all here together sharing our stories of success. Shouldn't we study ourselves in a way? Our history out there, and not just a big coffee table book, but that's great too. But I bet you all have stories. You could say, how did I overcome that? When did it start? When did I realize I needed to be different?
Yeah. Yeah, I think that you're bringing up something that's very critical. It was mentioned earlier by Deanna. There, for example, this study, the ABCD study, it's trying to compile multidimensional information about an individual, starting at 9 and 10 years of age, and follow them for 10 years. So it is a little bit of like a neurobiological, cognitive, behavioral sort of story that's being compiled at many different levels, from genetics, brain imaging, behavior, cognition, saliva, baby teeth, and quality of life. So I think sometimes these multi-level approaches perhaps can be akin to what you were suggesting, although I would love to hear the stories.
And when did we learn to be empathic? That's the number one thing we had to do.
Yeah.
Where do we do that? I think it's resilience we were practicing all along. That's just one hypothesis.
Yeah, no,
Interesting view, yeah.
John, please specify for us the status of ketamine. Is it FDA approved? For what indications? Is it first line or nth line after a year of failed treatment? Is it for certain subtypes of patients? What is the cost? Is it from a single manufacturer or more than one? Okay,
I'll try to. My working memory houses 4 items, so I've probably lost 3. So the status of ketamine right now is that the racemic ketamine, the combination of R and S ketamine, is FDA approved, which means that physicians can prescribe it for the treatment of depression. And various organizations like the American Psychiatric Association and Canadian and European and other organizations are beginning to endorse it for treatment-resistant symptoms of depression. S-ketamine is a variant of ketamine which is in late-stage phase 3 studies by Johnson & Johnson. There are other drugs that are capturing aspects of that are in earlier phases of development by other companies. We should have readouts at least on S-ketamine in a year or two. With racemic ketamine, in Connecticut, where we have established a clinic, insurance companies are reimbursing the delivery of ketamine for treatment-resistant patients. The early data, and it's very tentative, suggests that there's no real advantage of ketamine for mild symptoms of depression. If you have relatively severe symptoms or urgent need for depression despite other forms of treatment, ketamine is a reasonable option to consider, and there are a proliferation of centers around the country for that. One special case of ketamine efficacy so far, tentatively, is around the management of suicidal ideation. And there are small studies supporting this, large trials underway to see whether it has a distinct rapid effect on risk for suicide, which would be exciting if that turned out to be true.
Good.
I'm George Lundberg from Stanford and Medscape. The use of psychiatric medications is very widespread. Is there a practical way to use pharmacogenomics at this time to help better inform that prescribing?
The simple answer is no.
No.
I thought, okay.
Well, that was brief, Dan.
Deanna Barch from Washington University again. Huda, I wanted to follow up on what you said about the increasing rates of anxiety and to get your thoughts on how that might relate to the changes in the onset of puberty. So puberty has been coming earlier and earlier as, you know, especially in westernized countries, and I'm wondering how that might be interacting with increases in rates of anxiety and how that might be relating to brain development.
Yeah, I mean, I wish I knew. I think it's a really good observation because I said in passing, at least the way I think about it, is that that's the moment where, I mean, I think about steroid and steroid receptor and transcriptional regulation. So I think of gonadal steroids as reopening the ability of the chromatin and allowing some rewriting of the whole kind of transcriptional profile and beyond. And so if you're mistiming this and allowing it to happen sooner than people are, you know, ready in other biological way, the integration, the coordination with other things like the maturity issues that we heard about can be really off. If you put that together with social pressure, with lack of family support, or, you know, the huge influence of peers and all of that, you can see how all of this kind of is mistimed. And, you know, one thing I really liked this morning from Corey's talk, I liked all of Corey's talk, but one of the things I really liked is that we need to think about timing and duration of things and of fine-tuning and switching behavioral modules in a time dynamic way. And so this is a time that is dynamic, developmentally very dynamic, and lots of things are somewhat out of sync already, and anything that can push that. So synchronizing, what it takes to synchronize things is kind of a big question, whether we have it in us to do that, to help adolescents catch one kind of physiological system to another, is a really interesting and good point.
I want to add one aspect of it, which is, so yes, puberty is occurring earlier sometimes, it extending longer. I don't see that as a bad thing. This is, you know, human evolution, it is what it is. And I think that we all have to be cognizant of that, understand what the effects of puberty are, which a lot of you guys, including you, have looked at, that it is a sensitive period and a critical period for certain things. And just be cognizant of that. But it is what it is. It's what we have to deal with.
Yeah, no,
we have to.
Last question.
Okay, hi. Herb Kleber. I'm a simple country doctor from Columbia.
Upper West Side.
And I have a simple question for John Krystal on the ketamine thing. Could you give us a little follow-up? Does that patient need another ketamine once a week, once a month? Your one dose cured all? Could you give us a little more information?
Sure. So I'll just repeat the question is, what's the course of ketamine treatment look like? So we're running about between 7 and 10 infusions a day, twice a week in our ketamine clinic. Most people start getting an infusion twice a week for a short period of time. They go down to once a week. Then they are once every other week. On longer term maintenance, about 40% of the patients so far are maintained on once a month or less frequent infusions. So most people are getting relatively infrequent infusions and yet maintaining their antidepressant response for long periods of time. We've had people on for a few years. There are other centers that have had people on this kind of regimen for 4 or 5 years now. What's interesting to me, and not well understood from a scientific point of view, but I think important about the disorder is, so ketamine in the animal models helps the synaptic connections that are pruned by stress to rapidly regrow. Many other neural signatures, epigenetic, inflammatory, are also reduced, and yet the effect is time dependent. It's not about the length of duration of the drug, but rather the length of the duration of the brain's adaptation to exposure to that drug. Why does the illness come back? That is a mystery that we don't yet understand, even in people who have, like the woman I showed you, who gets kind of a complete remission from her ketamine infusions.
Thank you.
Okay, well, we've run out of time. I want to thank the panel and the audience for your attention. Thank you.